Good morning, everyone. Myself, Dr. Ghazal Patnaik, and I shall be presenting our work on preferred practice pattern in both Koyanagi-Harada VKH disease and Indian survey. So, what was the need of this survey? VKH is an old age disease since 1900s, but there exist dilemmas at every strata. Like starting from diagnosis, there is dilemma whether it evolved from Segura's criteria, which relied mostly on CSF pleocytosis, but it was invasive. So it went ahead to American Society of Uveitis criteria. They involved fundus fluorescein angiography in the diagnosis. However, over the years, it was failing to distinguish between an acute and a chronic disease. So then comes revised diagnostic criteria, but it also failed to distinguish between inactive and active, but it is currently the most used criteria to diagnose VKH. So the dilemmas started from diagnosis to imaging, where the place of fundus fluorescein angiography, OCT, ICG, indocyanine green angiography, as well as recently OCT angiography has been evaluated to play very important role at every stage of the disease. Coming to the management, there is a debate whether to have an initial oral corticosteroid or to have an earlier immunomodulatory therapy, whether to institute the immunomodulatory therapy within 3 months, or we can even start the immunomodulation as the first line for VKH. Coming to complications, we are most aware of that. The ocular complications is mostly cystoid macular edema. However, from the Indian studies, only 2 studies that has evaluated that the most common is choroidal neovascular membrane. So we desire that the patient ends up without any complication, maybe like this, having Dallen-Fuchs nodules, but mostly nowadays the complications are getting higher with subretinal fibrosis, exudative retinal detachment, even CNVM. So there was the need, and we aim to analyze the preferred practice pattern for managing a case of VKH, and we did an online survey from September 2021 to February 2022 amongst the Uveitis Society of India. So what we saw that there is a discrepancy between the VKH category being viewed by different groups, and we divided the groups as per the specialist years. That is, the uveitis specialist having 0 to 10 years of specialization were group A, 15 to 20 were group B, and more than 20 years was group C. And around 17 people did not reveal their information about the practice of years. So we compared the VKH category encountered by them, the most common ocular feature and extraocular feature, which was quite similar in all the groups. However, the images preference to differentiate between VKH and CSR, it varied from FFA, OCT and B scan as per the numbers. But if you see, it is common almost in all the groups, be it acute, recurrent or chronic convalescent stage. Due to constraints of time, I would be skipping the details. But when we come to the management practice, the duration of oral corticosteroids, there is a huge discrepancy between the earlier group and the group with more than 20 years of experience. The more than 20 years of experience, they preferred a 6 months of oral corticosteroid, whereas the younger one preferred 3 to 6 months of oral corticosteroids. Whereas coming to the immunomodulatory therapy, it was quite common, but there is a split amongst the younger individuals. Consideration of biologic is very recent. However, they do consider after 3 to 4 recurrent cases in all the 3 groups. Complication, however, if we see, they notice macular edema earlier in the course, where it shifts to sunset glow fundus and exudative retina when it comes to younger older experiences. COVID and just changes as the recent parameter, we analyzed that also, but there was no change, and there was a consideration that all the groups had a similar view. So to discuss, when we compared all the parameters between those with a less than 20 years and more than 20 years, we saw the form also changes. Probable is only the ocular manifestation, and more than 20 is incomplete. So over the year, the disease also progresses. What is more important here is the complication. As we see, the complication rate of the sunset glow, it decreases with the group. And to highlight here whether this could be highlighted to the duration of oral corticosteroids or the immunomodulatory therapy, as they also have a discrepancy. So to conclude, Many discrepancy prevails, especially regarding the management protocol. With the growing use of immunomodulatory therapy and the neurobiologic agents, it is a requirement not only to standardize the diagnostic criteria, but also to standardize the management pattern, so we can deal this dreaded disease and reduce the complication rate as it affects the middle-aged incoming people. Thank you.
Was a nice presentation indeed. I think you didn't disclose the financial interest.
So I do like no financial interest, obviously.
It's
It was
mandatory that your second slide should be that.
okay.
And just a piece of advice, don't mention your institute in your slide.
Okay.
It's supposed to be masked. However, seeing your co-author, we know where you're from.
Yes, ma'am. As I have discussed in the slides also, that younger populations, the discrepancy between the younger and the one with more experience is mainly the management. The younger prefers maybe 3 months of oral corticosteroids and 1 to 2 years of immunomodulatory therapy, whereas the more experienced uveitis specialists, they preferred 6 months of initial corticosteroids along with an early institution of immunomodulatory therapy. And when we saw the complication rate encountered by them, the complication encountered by the uveitis specialist with more experience is lesser and less dreadful as compared to the those experienced by the younger. So maybe it, yes, ma'am, that's what the prognosis was encountered, because this is an online questionnaire, so the exact visual acuity cannot be attained. We performed the questionnaire regarding the visual prognosis, so they gave the prognosis.